Thank you, everybody, for coming to Symposium 19, Demystifying CF-Related Bone Disease, from Pathophysiology to Treatment. These are our objectives. Each of our speakers will have 20 minutes to present, followed by about 5 minutes of questions and answers, and then we'll invite the next speaker. Once all 4 speakers have presented, we're going to invite all 4 speakers back to the stage for a group panel question and answer session. And so with that said, we invite our first speaker, Dr. Naeem Malouf, a professor of medicine from UT Southwestern.
So I'd like to start by thanking the organizers for inviting me to speak today. It's a pleasure to be here, and I'll be covering pathophysiology of CF-related bone disease. There is one disclosure in that my institution receives a grant from the Cystic Fibrosis Foundation regarding the bone disease, and I'll present one slide of data from that grant. So I'd like to start with a definition of cystic fibrosis-related bone disease, and the formal definition of osteoporosis is compromised bone strength predisposing to an increased risk of fracture. But I feel that a picture is worth 1,000 words. And here you can appreciate how on the left, you see a normal vertebra compared to an osteoporotic vertebra on the right. There are clear differences in the density of the bone, but there is also architectural differences. For example, in osteoporosis, there is preferential loss of the horizontal struts that keep the bone together. There are features of osteoporosis that cannot be shown in a picture, such as changes in bone turnover, the mineralization of bone may be different, etc. We are in this session because osteoporosis is extremely common in people with CF. This is one of the larger studies published now in 14 years ago in over 1,000 patients, 54% of which were men. Mean age was 29 years and mean BMI was 21. And across several studies, the average prevalence of vertebral fracture was 14% and non-vertebral fracture 20%. This is much higher than expected from people without CF at that age. And then the prevalence of osteoporosis and osteopenia was also very high. Now, when thinking of fractures in general, one has to think about several factors. Skeletal fragility is one, and contributing to skeletal fragility is low bone density, as I showed you, but also impaired bone quality. And then there is accelerated bone loss that can lead to both of these, and inadequate peak bone mass, which will be relevant to cystic fibrosis, and we'll cover in more detail. Of course, aging, hypogonadism, menopause, other clinical factors, and high bone turnover lead to accelerated bone loss. In clinic, we also have to think about mechanisms of fracture in some cases. Is there excessive bone loading, falls, or certain activities that predispose to fractures? Now, in thinking about the pathogenesis of osteoporosis, it's good to start with how bone mineral density changes with age. This is for the general population. Starting in childhood, boys and girls have equal bone density, and then there is a period in adolescence where peak bone mass is acquired. During that time, men achieve 10% higher bone mass than women. This is in large part related to differences in testosterone levels in boys. This is followed by a period where bone density is relatively stable or a plateau phase. And then with older age or senescence, there is a gradual decline in bone mineral density. Women experience a period of accelerated bone loss around the time of menopause that further contributes to greater risk of fracture, in addition to lower peak bone mass in adolescence. Now let's start with the peak bone mass acquisition in cystic fibrosis. This is a study from Stanford that looked at bone mineral density over time in boys and girls, or men and women, aged 9 to 25 with cystic fibrosis. The solid line represents the average for the general non-CF population. And some people with CF have similar bone density as the normal population, but you can appreciate a lot have much lower bone mineral density at a younger age. in particular, in filled circles and triangles are patients on glucocorticoids or prednisone, and those tend to cluster towards the bottom of the curve, meaning that glucocorticoid use is a significant risk factor for lower peak bone mass acquisition. Now, when I think of peak bone mass and its determinants in the non-CF population, the most important determinant of peak bone mass is genetics. We now know quite a bit about that. There are certain genes like the estrogen receptor or ER, vitamin D receptor, the RANK gene, and many other genes that contribute to the determination of peak bone mass. Additional factors that determine peak bone mass include adequate nutrition, including calcium, vitamin D, protein, and calorie intake. Hormones are extremely important, in addition to sex hormone, growth hormone, and IGF-1, but also cortisol, ACTH, PTH, etc. And then lifestyle is extremely important as well, especially in adolescence, where increasing physical activity can make a big difference in achieving higher peak bone mass. What about in CF? Well, to start with, people with CF has an abnormality in their CFTR, and that alone could be contributing to low peak bone mass. This is primarily based on animal studies. Here I'm going to show you some rodent data showing that the F508 deletion in CFTR can impact bone formation irrespective of what else is going on in these animals. CFTR, for a fact, is expressed in bone cells, but more importantly, when this deletion is introduced in an animal model, here you can appreciate to the bottom, there is lower trabecular and cortical bone mass compared to wild-type male and female animals. You see how these trabeculae are much thinner, and you see more cortical porosity or holes in the cortex. When you examine this histologically, comparing again wild-type to deleted animals, you can appreciate how there is less trabeculae in purple here compared to the wild-type animal. And when this is quantified histologically, the thickness of the trabeculae is significantly lower in animals with the deletion, both in male and female animals. There is greater separation between the trabeculae, so greater distances, which is an adverse finding. And then when looking at bone volume per total volume, this is a surrogate of bone density. No matter the age of the animals, 6 weeks, 10 weeks, or 14 weeks, which could correspond to pre-puberty, puberty, and adulthood if you want. The animals with deletion have lower bone mass or bone volume per total volume. In addition to the adverse genetics, there is pancreatic insufficiency in CF that can contribute to calcium, vitamin D, and vitamin K malabsorption, further worsening bone mass. Pulmonary disease, we've known in many studies that low FEV1 infection or inflammation contribute to worsening bone density. And then finally, certain medications, specifically glucocorticoids, can contribute towards bone mass. Next, I'd like to move to the plateau phase of bone mass, which is what occurs between age 25 and 50 in adults. In general, in healthy individuals, bone density is stable. What about in CF? This is a publication from earlier this month in the Journal of Bone and Mineral Research, looking at 500 adults with CF from Canada, aged 25 to 48, followed between 2000 and 2021. And here you see the slope for lumbar spine and femoral neck bone mineral density. Each gray line in the background is a single patient, but on average, there is a decline in both lumbar spine and femoral neck BMD during that period where a plateau is supposed to occur. In fact, over this period, there was a 19%, on average, 19% decline in bone density, which is equivalent to 0.8% per year at the femoral neck and 11% or 0.5% per year at the lumbar spine. The investigators tried to correlate what predicts this bone loss in adults, and there was no interaction between bone density change and sex, CFTR genotype, the presence of CF-related diabetes, or vitamin D levels. However, one factor that was a significant determinant was the presence of pancreatic insufficiency. So the solid the dotted lines represent patients with pancreatic sufficiency, solid lines insufficiency, and at the lumbar spine you can appreciate the difference, same at the femoral neck. So clearly pancreatic insufficiency contributes to this decline during a period when bone density should be stable. So going back to this graph, I've showed you that people with CF have lower peak bone mass and are losing instead of maintaining during the plateau phase. There's very little data telling us what happens beyond that. I could not find much in the literature on this topic. But clearly this is going to be important because, as everybody in this room knows, the life expectancy of people with CF has increased so much. This is data from last year, a publication showing what was the median age at death in 2008. In CF, it was 26 versus 75 in people without CF. You can appreciate how the great advances we've made have improved that to 66. And again, this is a period of senescence, and if people with CF are starting with low bone density, we don't know what will happen to their fracture risk. Next, I'd like to move to the determinants at the cellular and molecular level for changes in bone density. So we think about bone mass as this continuum between bone formation and bone resorption. In an ideal state, these two processes are equal. However, we know that certain factors like mechanical loading and immobilization can worsen bone formation. Immobilization can increase bone resorption. Estrogen deficiency and low calcium absorption through high PTH can lead to greater bone resorption. At the cellular level, there are two major players, osteoblasts that build new bone and osteoclasts that resorb bone. And then osteocytes are these older osteoblasts that are now inside the bone matrix. Receptors for important molecules or for drugs that we use are shown here. So calcitonin has its receptor on osteoclast, PTH, the parathyroid hormone receptor, is on osteoblasts. And estrogen is very important in the interaction between these two. Estrogen interacts with receptors in the nucleus. Sclerostin is another important molecule that is secreted by osteocytes and inhibits osteoblasts through its interaction with the Wnt signaling pathway. And we have drugs that block sclerostin that I won't be covering today. But the important effector molecules in this relationship between osteoblasts and osteoclasts are the rank ligand, and OPG. So rank, or receptor activator of NF-kappa B, is this important receptor on osteoclasts and osteoclast precursors. It interacts with rank ligand, its ligand that is secreted by osteoblasts. And whenever that interaction occurs, there's greater osteoclastic resorption. We now also know that osteocytes can secrete rank ligand. This is how our bones know to repair or to bring osteoclasts to repair old bone. This is sensed by osteocytes, and the osteocytes call the osteoclast through rank ligand. Importantly, our bodies have, and I didn't show this or didn't say it, but the progression from osteoclast precursors to mature osteoclast is also dependent on the rank ligand interaction. Our body also produces OPG, or osteoprotegerin. Osteoprotegerin is this decoy receptor that can block the interaction of rank ligand with rank. So you could think of rank ligand as the bad actor and OPG as your protector. Think about osteoprotegerin to protect the bones. This is important both from the standpoint of pathophysiology, but also pharmacologically, because we have a drug, denosumab, that blocks the interaction, or denosumab mimics the effects of OPG. So about 20 years ago, the discovery of the rank ligand and OPG was a very important discovery in our understanding of molecular mechanisms of inherited and acquired bone disorders. For example, there are two congenital conditions, one of osteopetrosis of high bone mass, in which there was a congenital deficiency in rank ligand, and in a form of Paget's disease of the bone where there is excessive osteoclast due to OPG deficiency or mutations in the OPG gene. And so one can understand why, if you don't have this bad actor that drives your osteoclastogenesis, you cannot break down bones and you develop osteopetrosis. Whereas if you have no OPG, rank ligand acts unabated to cause bone resorption. So the Rankel OPG ratio is something worth following. And this is important not just for these rare congenital conditions, but we now know that in several conditions, there's changes in rank ligand and OPG that increase this ratio, further contributing to osteoporosis. This includes estrogen deficiency in menopause, multiple myeloma, HIV with osteoporosis, even in the joints of patients with rheumatoid arthritis where there is active erosions. This seems to be driven by rank ligand. And then chronic glucocorticoid use is also a driver in this. So how does this interplay with CFTR? Well, CFTR turns out regulates the production of OPG by osteoblasts. And in fact, the osteoblast phenotype in these delta F508 CFTR mice have reduced OPG production. This has been worked out very nicely, but importantly, one may be able to block the signaling to increase OPG and reverse bone loss. I'm going to show you one slide on rank ligand in CFTR. This is from unpublished work done in the lab of Dr. Dwight Towler at UT Southwestern. He compared the C57 black mice compared to CFTR knockout mice, and in red you see the massive increase in rank ligand production in those animals. But how is this relevant to humans? Our group has looked at that, and we published last year in the Journal of Cystic Fibrosis a comparison of rank ligand and OPG, Rankel and OPG in healthy volunteers, CF patients, people with CF and no bone disease, and CF with bone disease. And you could see how serum rank ligand increases progressively from healthy to CF with no bone disease to CF with bone disease. OPG levels are much lower in CF, but not different in those with and without bone disease. And if one looks at the ratio is significantly different between those three groups. Other investigators, this is our data. I've shown you how compared to non-CF, CF with no bone disease have high rank ligand, low OPG. CF with bone disease, much higher rank ligand and low OPG. But there are other studies in this field, one in 24 adults published now in 2010 that showed, in that case, low OPG, not so much of a difference in rank ligand. There are also studies in adolescents. Here, there was no clear bone density available, but in that study of 35 healthy and 35 people with CF, rank ligand was higher and OPG was lower. And then most recently, in a study just comparing CF with no and with bone disease, OPG levels were on the low side, but no difference in rank ligand. So I'd like to add cystic fibrosis with bone disease to this list of acquired/congenital conditions in which you have high rank ligand and low OPG. But I have to say there are several caveats to this. There are different assays to measure Rankel and OPG, and that can be a problem. We have to keep in mind that the circulating levels may not necessarily reflect what's happening at the level of the bone. In CKD, there is some accumulation of OPG, so we have to be careful in interpreting that. And then rank ligand is secreted from other cells, from activated C cells, synovial cells, like I mentioned in rheumatoid arthritis, and there is OPG production from cells in the thymus. So circulating levels may not necessarily be what the bone is showing. But I'm going to end with a summary here, saying that people with CF achieve low peak bone mass and experience accelerated bone loss in adulthood, resulting in greater risk of fracture. CF-related bone disease is multifactorial in etiology, starting with the fact that CFTR is expressed in bone cells, to pancreatic insufficiency, inflammation, glucocorticoid use, and others, and that the rank ligand OPG is critical in bone metabolism and dysregulated in the CF population. I'd just like to end with this phase cover from Science from 35 years ago. That's the date when the identification of the cystic fibrosis gene was first described. The paper says chromosome walking and jumping, and it's very interesting to read. But I have to say that over these 35 years, we've made great strides, and the future is only bright. I'll end here, and I'll be happy to take questions.
Thank you, Dr. Malouf, for excellent talk. We can take questions at the mic or in the app. Maybe I can ask the first question. I was very intrigued with the JBMR paper showing that the patients with CF had accelerated bone loss with pancreatic insufficiency. Any explanation why? Is it nutritional? Is it vitamin D related?
Yeah, so those investigators, well, first I have to say they excluded patients who had transplant and patients who had received anti-resorptive medications. But when they adjusted for vitamin D, they could not explain the difference by vitamin D levels per se. They were repleting vitamin D adequately, so vitamin D did not seem to be the explanation. Not sure whether pancreatic insufficiency is a marker for something beyond vitamin D, like calcium malabsorption or other factors that they were not able to answer through this population level.
Okay, great. Thank you. You have any questions in the app?
So you talked a lot about bone turnover. Could you comment on the clinical utility of bone turnover markers when we're providing patient care for these people with cystic fibrosis?
Yeah, so that's a great question. The use of bone markers is a tricky one. One has to be careful with which markers to choose, number one. Number two, in children, bone markers tend to be higher because they're growing. So I personally use them at in very select patients. So when I'm trying sometimes to decide on treatment or treatment discontinuation, but I do not use them in all patients. I selectively use them. And when I use them, I tend to use serum CTX. That's a marker of bone resorption, but it has to be drawn fasting in the morning under specific circumstances to be able to follow that all the time.
Question at the mic?
Yeah, thanks, Vin. I wanted to follow up on Vin's question. Andy Kelly, we met earlier, Philadelphia. This difference between RAG ligand in the presence of CF bone disease and in the absence of in CF but without bone disease is really intriguing. And I'm wondering, do you know what is prompting or have any ideas about what's prompting that increase in RAG ligand? Because I think that would get to Vin's question. And are there any longitudinal data to show changes in RAG ligand as people age or perhaps this CF lung disease progresses?
Yeah, that's a great question. So I'm not aware of any longitudinal data or where you check RAG ligand and then follow the patient to see whether that predicts bone loss. However, our study is still ongoing at UT Southwestern, and we think with a larger sample size, we will be able to tease out what factors predict the higher levels of RAG ligand, or what differentiates those with and without bone disease through RAG ligand.
I just want to follow up with one more question about the CFTR mutation. And is it an issue in the osteoblasts that's causing increased RAG ligand, or is there an issue with the osteoclasts? What cell is causing the CF bone disease?
I think based on my reading of the literature, it's the osteoblastic production of OPG, which is the protective molecule. That seems the clearest molecule. I showed you one slide with RAG ligand from UT Southwestern, but from what's published and what we've seen also, the low OPG production by osteoblasts seems to be the clearest if you were to think of what's
Okay, great.
Thank you so much, Dr. Malouf.
Thank you.
Thank you. Our next speaker is Dr. Kristen Williams from Columbia, and she'll be talking about how to screen for CF bone disease.
Right. Can you hear me?
Yes.
Okay. So good afternoon. Thank you for the introduction, the invitation from the conference organizers and session moderators. So in addition to understanding the pathophysiology of CF-related bone disease, we need to review how we assess bone health so that we can better, have preventative or therapeutic decisions and measures incorporated into the treatment of individuals living with CF. So I have no relationships to disclose related to the presentation. And so for our objectives today, for this talk, we're going to talk about the key terminology related to CF-related bone disease. We'll compare the different imaging tools we have available to us to look at bone mineralization and fracture risk. We'll review the available screening guidelines that assess bone mineralization, fracture, and how we determine follow-up testing. And then we'll briefly touch on secondary causes and that evaluation for individuals living with CF. So for our key terms, the first one, of course, is DEXA. So that's dual energy X-ray absorptiometry. So this is our primary imaging tool to measure bone mineral content and bone mineral density. And we're doing this at specific skeletal sites with the overall goal of assessing bone strength and fracture risk. So in older adults, the outcome measures are reported as T-scores. And this is where you're comparing the individual scores to a healthy younger reference population. And then in younger adults, we're using Z-scores. So this is comparing to their age and gender matched peers. Low bone mineral density, this is where you have in the older adults, T-scores less than -1 standard deviation below the mean. And for pediatrics, teens, or young adults, we're using a Z-score less than or equal to -2 standard deviations below the mean. And ideally, as we'll talk about in a little bit, you're adjusting for height, race, and ethnicity is available. So you'll frequently see in reports and registries the term osteopenia. So low bone mineral density is the preferred term in adults, and ideally we're avoiding this term as a diagnosis in children and young adults. For osteoporosis, this is characterized by low bone mass and alteration in the microarchitecture leading to fragility. So in older adults, that's a T-score less than -2.5 standard deviations below the mean at the femoral neck. And in children, teens, young adults, we don't diagnose osteoporosis based on their Z-scores alone, but you would have either low bone mineral density with a significant fracture risk, and by that I mean two long bone fractures, low trauma femur fracture. Alternatively, if someone has a vertebral compression fracture, irrespective of their Z-scores of their DEXA report, you would consider that osteoporosis in this age group. And then finally, a fragility fracture, which is what we're so mindful of. This is a low energy, minimal trauma-induced fracture, and the key predictor of future fracture risk. So DEXA is the gold standard for diagnosis and evaluation of bone disease. It's widely available, it's low cost, scanning times are pretty quick, and there's very low radiation exposure. And really, DEXA should be obtained if you're going to use those results to influence your therapeutic decisions. The initial screening and frequency depends on age and clinical status, and follow-up depending on what their prior reports show. And while there's no absolute contraindications to screening, if they've had recent oral contrast, if there's non-removable hardware in the region you're wanting to measure, if they can't obtain correct positioning on the table, or if they're pregnant, you would probably avoid at that time. So the International Society of Clinical Densitometry position statements from 2019 help define the preferred skeletal sites that you're going to do for bone health assessment. So in adults, this is your femoral neck, your total hip, lumbar spine, potentially the forearm, depending on the clinical history. And then in children and young adults, this is your whole body minus head or your lumbar spine. We have robust reference data for these regions, higher scan precision, and more easily identifiable landmarks that help with the scanning process. In these patients, you might also consider the femur or the forearm, which we'll talk about. So the more recent International Society of Clinical Densitometry pediatric position statement also now talks about the applicability of forearm DEXA scans. So this would be the distal 1/3 radius and the ultradistal radius. So why do we care about the forearm? We know it's a site of increased fracture risk both in children and adults. The distal 1/3 radius is actually, the measurements are less affected by height and conditions that affect linear growth. So that's important in individuals with chronic illness. The radius sites are easy to measure, especially if you have hardware. If the patient has trouble lying flat, say they have contractures, it's much easier to get this area, or if there's a history of immobilization. So as you can see here on the right side, so the bone mineral density in childhood study, they reported in 2020 outcome measures looking at DEXA radius sites. And while the distal 1/3 and ultradistal radius outcome measures are less predictive of overall long bone fractures, we do see that there are strong correlations between ultradistal radius and measures of volumetric bone mineral density and aerial bone mineral density at the lumbar spine and hip. So these could be good alternative or additive heights with our bone assessment. So in children, we talked about you get whole body and lumbar spine, but the total body DEXA Z-score, it's an average of the entire skeleton. So if you have deficits in weight bearing, this could be masked by normal upper extremity bone mass. So the hip, which we know is a clinically significant fracture site, higher risk of morbidity and mortality, it can contribute to overall bone health assessment, especially in individuals with chronic illness who are younger. We now have more normative data for these younger age groups to look at femur sites, and it may be really helpful as we're discussing longitudinal measurements, especially in that transition period between our teens and younger adults into adulthood. There's conflicting reports on fracture prediction using the hip in younger populations with DEXA, but there have been studies that showed strong correlation, especially with the lateral distal femur DEXA measurement Z-scores and risk of lower extremity fracture in non-ambulatory patients. So we've talked a lot about DEXA, but it's really important to be mindful of any limitations. So DEXA reports are outcome measures of a 2D image of a 3D space, and that's our aerial bone mineral density. And so this accounts for 60 to 70% of our bone strength. And so it's a good surrogate for bone quality and strength and fracture risk prediction, but it limits our ability to actually detect depth of bone. And so therefore it's truly an imperfect estimate of true volumetric density. So as a result, you could see that if you have smaller size bones, the DEXA may underestimate the bone mineral density, and conversely, it could overestimate scores for taller bones. And this is important as we're tracking, especially in younger children as they get older. If you have a decline in your bone mineral density Z-scores and subsequent follow-up scans, this could actually be due to just poor linear growth as opposed to decreased mineralization. In the same way, if you have increased bone mineral density, this could be artifact due to increase in bone size. And then something that we always talk about, especially in someone who may be at risk of fracture or has fracture, that if you've had a vertebral compression fracture, you can actually see an increased bone mineral density score. And that's because the total volume of the vertebral body is decreased, but the total mineral content is the same, right? So overall, you have an increase in bone mineral density. So this brings us to the fact that there's been a lot of research looking at height adjustment of DEXA Z-scores, which is very important. So shorter stature, delayed puberty, these can lead to smaller gains in aerial bone mineral density and a relative fall in Z-scores. So how do we account for this impact on height? So there's been many studies in individuals living with CF looking at height Z-scores to adjust DEXA outcomes. So in the study that you could see on the left, there were 82 children and young adults with mild to moderate CF that Dr. Kelly and her team looked at, and they looked at whole body and lumbar spine bone mineral content. And then what they did was they adjusted for Z-scores. So the left chart shows you the CF population had significantly lower Z-scores in the unadjusted model. But then when you look in the right, we can see here that when they adjusted for height Z-scores, the difference was no longer statistically significant. In a follow-up to the bone mineral density in childhood study, the team assessed other measures of height adjustment. So they looked at age, height-specific Z-scores, bone mineral apparent density, I'll talk about in a second, and then and then they looked at height for age Z-score. So that's listed here as the HAZ adjusted. And this helps to account more for somebody's pubertal status and in addition to their stature. And so in this study, when they adjusted DEXA for the height for age Z-score, it was found to be the best approach to limit the effect of stature on the outcome measures. And on the right, this was a study from over 100 children with CF in Australia, followed over 16 years. And when the team went back and analyzed the baseline data for height for age Z-score adjustment, they found that to be the biggest driver of future bone mineral density outcomes. So this can have an impact on our screening intervals and future recommended guidelines. So CHOP has published a tool to help calculate bone mineral density for age Z-scores and actually the height for age Z-score adjustment. I use this all the time. And this can help you with your management decisions and trending serial measurements. The International Society of Clinical Densitometry also endorses another method of height adjustment. So if we're assuming that vertebral bodies or bones are more cuboid or cylindrical in shape, you can actually use a mathematical transformation of bone area from DEXA to estimate the volumetric density, and it better approximates the bone size and depth, and that's your bone mineral apparent density. We have now age, gender, population-specific reference data, even for younger children and up. And in some studies has been considered the least biased measure of bone mineral density relative to height, when even adjusting further for height for age Z-scores. The team Crabtree et al. In 2013 reported on all different size adjustment techniques in children with and without fragility fracture. And they found that while adjusting for size in general improved the predictability of DEXA to determine fracture risk, bone mineral apparent density was the most accurate predictor for vertebral fracture. So when we bring this information back to the clinical space, you'll get a DEXA report, right? So for this individual, this is a teen male who has pancreatic insufficiency, difficulty gaining weight, impaired height growth. And so what we're looking at is the DEXA machines. It's from a hologic machine. We're looking at his lumbar spine results. So in the report, you can see the total lumbar spine. There's the T-scores, but as we talked about, he's younger, so we're looking at his Z-scores, what's listed as -1 standard deviation. So that's not considered low bone mineral density. If we adjust further for his height, because we said he had shorter stature, we can see the height for age Z-score using the CHOP calculator is actually now -0.01 standard deviation. So this is really important as you're tracking individuals through growth. Different variables determine how we interpret changes in DEXA reports over time. So each bone center, each machine has to calculate its own measures of precision errors and something called least significant change. And there's a lot of maintenance of the integrity of scans, setting up time frames of future developments, quality control. And so precision error is essentially the degree of reproducibility of bone mineral content or density measures for a specific machine and even a specific operator or technician. And that error is used to determine the least significant change. So that's the smallest difference in serial DEXA outcomes that we consider statistically significant. So when you get a follow-up report, as you see here on the right, you're going to look at your T or Z scores that you have following the individual, but you're going to look at what is the percent change and whether that's denoted as significant. And that will help you just determine, further evaluation and discussion of treatment. But because there's such specific measures for each center and scan, it really limits our ability to compare across either different machines or different centers, whether you're looking at a patient who's moving to a new location or you're doing research. The Bone Mineral Density and Childhood Study team in 2020, they also reported on intermachine variability. And they looked at what are the rates of low bone mineral density Z-scores at the centers used in their study that helps create reference data. And they also compare different outcome measures from different skeletal sites using a shared phantom, which is the device that helps calibrate the scanners. And so the whole body measures of the study participants had the widest intermachine differences from centers, and the hip had the least. So it really highlights the importance of longitudinal scanning on the same machine and same center as possible. Also being really considerate of if you're doing research at your center, having a control group and not just using reference data so you're comparing on the machines that you have. Within our clinical care of patients, documentation of bone health is really crucial. And so as you would see here on the bottom right, this is what you would see in a clinical encounter, and in the larger picture, what you would see in the annual report. And the annual report asks about, have there been DEXAs in that year, and what are the results of that DEXA? There's ongoing efforts from the CF Foundation, from the registry support teams and subject matter experts to really update this section to reduce any interpretation and documentation error regarding the diagnosis of low bone mineral density and osteoporosis, especially when you're using that registry to track overall bone disease outcomes. So we have some other tools outside of DEXA to help better look at bone microarchitecture and mineralization. Quantitative ultrasound, this is actually a very low cost portable tool. It's not large, and it helps calculate bone mineral density, compressive strength, and without any radiation. It looks at the heel and the phalanges, and we have validated measures and references and reference data in older individuals. There have been studies that show that quantitative ultrasound measurements of density correlate with aerial bone mineral density outcomes in adult with CF who've had DEXA. So could potentially be used to screen out patients who have normal bone mineral density, maybe reduce burden of screening. We also have MRI. MRI is used in the clinical and research setting. So it measures volumetric bone mineral density, bone microarchitecture, can evaluate vertebral anomalies in the presence of fracture. There's no radiation, but it's definitely higher cost, longer scanning time, and if they don't want to be confined to the tighter space, that could be difficult. Quantitative CT is another more research-based imaging tool that we use in bone health, and this gives us 3D measurements of actual volumetric bone mineral density. You can either image the non-dominant radius and tibia, that's your peripheral QCT, or the spine and hip, which is more central. It's less affected by bone size or surrounding adipose tissue. And there have been studies in individuals with CF looking at this imaging tool. So one study to measure volumetric bone mineral density in teens and young adults showed that there was abnormal bone microarchitecture, altered trabecular and cortical bone, as well as reduced strength, even when DEXA scores were reported as normal in those individuals. So peripheral QCT may detect early bone deficits. The limitations of this scanner is higher cost. There's significantly more radiation exposure, so we're primarily using these in research settings. So let's go back to the why. Why do we screen? Why do we educate patient and families about bone health? And really the goal is to reduce fracture risk. We know fracture can impact quality of life, increase chronic pain, interfere with PT, transplant eligibility. And so we know that fracture risk increases with lower aerial bone mineral density and content Z scores. There have been studies, one that came out of Germany of adults with CF that showed bone mineral density and content were lower for those who've had more than one clinically significant fracture. But we've also seen from other studies that you can have bone fragility and fracture even if the Z scores are within range. There are other tools out there that help with fracture risk assessment. So FRAX, the fracture risk assessment tool. This is a computer-based algorithm. You'll see this in DEXA reports frequently, and uses clinical risk factors to estimate an individual's 10-year fracture probability, but it's only validated in individuals over the age of 40. Other tools that we have to actually detect fracture, so vertebral fracture assessment. This is using DEXA images of the spine. And what it essentially has is a scoring system that looks at the % reduction in height of the vertebral body, either within the body itself or comparative to consecutive vertebrae. It's low cost, it's low radiation compared to a traditional x-ray that you might get to look for vertebral fracture, but it's very sensitive to reader expertise. This tool has been validated in children with osteoporosis and leukemia. It's been shown to aid in prediction of new vertebral fractures in a 5-year period. And so if it's available at your institution, you might obtain it if somebody's having lower bone mineral density scores, if they've had a prior vertebral fracture, if they've had prolonged steroid use, or if you're looking at healing and remodeling after a treatment with bone modifying drugs. Other tools that we have to measure more bone geometry or biomechanical properties. So hip structural analysis, this is DEXA data at the proximal femur, and it's looking at bone mineral mass distribution and hip strength. And this helps assess femoral neck fracture risk. There have been studies that show a high degree of correlation between HSA measures and measures of volumetric bone mineral density. We also have trabecular bone scores. So this is complementary data to our lumbar spine and femoral DEXA. And this uses spatial models to give more information about the bone microarchitecture. We know that lower values correlate with weaker microarchitecture and increase fragility fractures. So you may see these incorporated into your DEXA report or your FRAX scores. So what about screening? When do we screen? So there are different screening guidelines available to us. The CF Foundation guidelines were posted in 2005, the French CF Society guidelines in 2008, and the European Society guidelines in 2011. you'll see probably the baseline DEXA difference is the biggest of when you start screening. And part of that might be due to the fact that the CF Foundation Clinical Care Guidelines were published prior to the updated International Society of Clinical Densitometry guidelines in 2007 and then 2013, when we had more normative data for DEXA outcomes in younger individuals. So per the CF Foundation guidelines, we recommend routine screening for individuals 18 and up. And for those who are 8 years or older, if they're higher risk, so lower body weight, lower lung function, chronic steroid use, or delayed puberty. And the follow-up screening, when do you repeat the DEXA, really depends on the initial report. However, if you have the change in clinical condition, somebody's about undergoing transplant evaluation, you're worried about a higher steroid burden, you might consider a DEXA sooner. I know Dr. Ulal is going to talk a little bit more about evaluation, but essentially when a patient comes to see me, when they've had a DEXA report that shows potential impaired bone mineralization, the first thing I'm doing is actually looking at their height and overall growth, making sure that it's truly consistent with low bone mineral density. And then, of course, we're doing our clinical evaluation, nutritional status, dietary review, using pancreatic enzymes. Are they getting weight-bearing exercise? Many labs that we look at, especially in a growing child, this is what we would do, not even necessarily for someone with CF, but celiac disease, thyroid, parathyroid status, pubertal status. And then sometimes we get other imaging. So if someone's presenting with lower bone mineral density and they're talking about recurrent back pain, maybe I'm getting an X-ray if I don't have VFA available, especially if they've had recurrent glucocorticoid use. Once again, VFA, if it's available at your institution, it's not available at mine. And then maybe even MRI if you really need more of a dedicated fracture evaluation. So for future directions, I think what's really so important is just ongoing awareness and education about the importance of bone health in a growing population, or bone health assessment, why it's important to get the DEXA, even though we know it's an added extra burden, and how do we interpret those results, understanding all of their limitations. Looking at future studies, maybe alternative sites such as the hip in children and young adults. Do we need to be checking that sooner? Do we need to be trending that as they're transitioning to adulthood? And then all of these other imaging tools and applied models that we have at our availability, will that help reduce the frequency of screening? Can that help better aid in fracture prediction and any therapeutic decisions or recommendations that we'll have? So that's it. I don't know how to go back. Thank you.
Very nice talk.
Thank you.
My question relates to fat, obesity, and how that may impact DEXA measurement. Do you have any thoughts on that?
I don't know if Dr. Kelly's going to be talking about body composition. No. I would have to get back to you on that. But it's definitely something that we are looking at, right? All the fat spaces. Yeah.
Great talk. Hossein Sadeghi from Columbia University. Is there any point, we emphasize exercise for our patients. Is there any point in doing any DEXA scan screening or any assessment of their bone health before we get them engaged in contact sports?
In terms of whether or not they're going to be more at risk of fracture?
Fractures.
I don't believe there are guidelines saying that is necessary, but I think just incorporating that into the conversation about how they are at risk maybe will help them to do the DEXA when they should, when it's recommended for screening. But it's not something that I get if somebody is about to go play football, but I do definitely encourage exercise.
My focus is mainly for global patients who are really malnourished.
Oh.
Is there any point in advising them, okay, before you play football or what we call soccer?
Yeah, I think about our younger population in general, that how frequent we would even consider treatment unless they've actually had fracture. So I'm not sure a DEXA will be the most helpful at that point. I think just the exercise is probably so beneficial, although I'm not a really big proponent of football, so sorry. Not watching it, just younger children playing.
I had a question. Great talk. I'm glad you mentioned fracs. It's a very common question. Two-part question. Do you check secondary osteoporosis on the fracs? And Do you think, what are your thoughts on using different fracture thresholds on fracs, given that CF patients have higher rate of fracture?
Yeah, honestly, I'm pediatric, so none of my reports even come with fracs.
Okay.
So I haven't had to deal with that.
Okay. Thanks.
Apology.
Hi, Matt Bowman, a physical therapist from Syracuse, New York. I'm talking in a bit of a response to his question and your answers. There actually is a predictive model for children 8 to 17 that we use in our clinic. There's five parts to it, and I'm having trouble recalling them because they're on our Epic smart phrase, but it's basically a 10% loss in BMI, previous history of fractures, glucocorticoids, 90 days in a calendar year, and then there's a couple more that I'm forgetting off the top of my head. But it is put out there by the CF Foundation. So that would be a good way to screen. And if any of those come back, any of those 5 come back positive, then that triggers a request for a DEXA.
Yeah, and so we try to follow that as well. I think it's really important, and great that your team is reinforcing that. I think as many members of the team can reinforce the importance of bone health assessment and actually getting the DEXA scan. In my clinical history, the biggest issue is actually getting them to, there's so many barriers to actually getting the scan, whether you can explain it well, whether you get buy-in from the family and the patient. If the DEXA is at a different location, if they can't get it during their 2-hour visit, the bone center in my institution, the waiting lobby is very packed. They're around a wide variety of individuals. So infection control, whether the appointment they can same day or not. So I find that one of the biggest issues is actually getting them to the door of screening, whatever their risk factors are. So the fact that your group is incorporating that into their care with strict measures to show to the patient, this is why it's so necessary, right? This is not just another checkbox that you need, but you've had these risk factors. So that's really helpful.
Yeah, thanks.
Thanks.
Thank you so much, Dr. Williams, and we'll save the rest of these questions for the panel discussion. And we now invite Dr. Kelly, Professor of Pediatrics from Children's Hospital of Philadelphia, to be our next speaker.
All right, Dr. Tangpricha and Dr. Wu, thanks for having me. Okay. I have no relevant disclosures other than Dr. Wu, unbeknownst to Dr. Tangpricha, has promised me an extra 5 minutes. I'm presenting on behalf of the Promise team. I wanted to before I even start, special thanks to Rachel Allega, my program manager, who is responsible for organizing all the DEXA from the 16 sites that sent DEXA our way. Babette Zemmel, whose name you saw frequently, she's responsible in great part for the bone mineral density in childhood study reference data that we have. And she went through every DEXA painstakingly, looking for ones that should not be used, did mirroring if someone had, say, an insulin pump on one side and a CGM on one side, and is also the reason that I only got these data from Promise 2 weeks ago. So I'm not as articulate as I'd like to be on the results, but you'll bear with me. As well as Megan Shirley, who is now part of the Promise team as well at CHOP, and she'll be presenting the ETI data from Promise tomorrow, slightly differently than how I'll be doing it. So, goals. I'm just going to review briefly some of the available data on CFTR modulator therapy and bone. Review the goals of Promise, endocrine substudy, and some data that informed them. And I will, I think really importantly, consider some lessons learned from this multi-center study. Okay, so first, ivacaftor and bone. This is registry data from the US and UK. And they looked at reports of arthritis, arthropathy, bone and fracture, osteopenia, and osteoporosis in the 2 to 3 years following initiation of ivacaftor. And my colleague, Dr. Williams, has already noted to you that there are some problems with registry data when it comes to DEXA, but that we should be unbiased and should affect both our ivacaftor and our ivacaftor naive patients. And what you can see is that the prevalence of quote unquote bone and joint issues was lower over that subsequent 2 to 3 years. So this gave us some hope that perhaps modulator therapy might have a benefit to bone health. Melissa Putman, for her K23, did a 2-year prospective study of DEXA and HRPQ-CT in adults, 15 adults and 11 children, treated with ivacaftor. She looked at, right here is the baseline data, ivacaftor, individuals with CF not treated with ivacaftor, and otherwise healthy individuals. Here are the data in adults. And what I want to draw your attention is that, like what's been discussed earlier, the hip seems to be perhaps a site of vulnerability for patients with CF. I'm going to come back to this concept. In our youth that she had recruited, not much in the way of differences between individuals with CF and her controls. Most importantly, she demonstrated no changes in Z-scores in either the adults or the pediatric population at multiple skeletal sites over the 2 years following ivacaftor initiation. Here are some of the data from HRPQ-CT, so thank you for Dr. Williams for introducing this concept. This is of the tibia, and what Dr. Putman demonstrated is that cortical area increased at both skeletal sites versus the CF controls and healthy volunteers. I'm going to come back to this concept later, but that might be either that the outer shell of the bone is expanding or the inner bone is expanding, so you're getting more area. And this may be relevant for some of the findings we have in youth. No apparent differences in youth treated with ivacaftor. These are difficult concepts. We don't have Z-scores or good reference data for HRPQ-CT in youth, although my colleague, Dr. Mary Leonard at Stanford, does have some reference data that we can often use. But you can imagine in a growing child whose bones are getting bigger, estrogen altering that endocortical, so that inner bone, these seeing changes may be difficult in growing children. So what was the PROMISE endocrine sub-study? It's ongoing. For the endocrine sub-study, we had a number of goals. Our main goals were to look at lumbar spine, total body, and total hip velocity Z-scores. And I want to acknowledge that we are measuring hip, even though hip has not generally been recommended in the setting of CF as a screening measure. We're also looking at Z-scores. And then in the adults, we had my colleague and I, Mike Stalvey, as we were developing this, said, oh, we'll do total body, less head. One of the lessons learned, and I'll walk through this. We were hoping that we could generate Z-scores for the entire cohort and have a more powerful model by doing that. I'll show you why that was challenging. I'm going to come back to this concept, though, of velocity Z. So anyone who's a pediatric endocrinologist in this audience will know what this is, my favorite growth curve. For those who are not pediatric endocrinologists, poor you, I will walk you through this. Here on the x-axis is age, and then this is velocity. This is how quickly we grow, centimeters per year, inches. And in childhood, you're growing at sort of a standard rate, maybe 2 inches a year. And then you have peak growth velocity occurring in girls in about 13 and a half and boys in about 14 and a half, and then you're slowing. These are early maturers having peak velocity earlier, and then later maturers having their peak velocity later. I want to acknowledge that when Tanner developed these growth curves, not everyone has a peak velocity exactly at 13 and a half. He took this wide distribution and said, oh, let's superimpose them. So this is really nicer than reality. But based upon this concept, I wanted to develop bone mineral accrual velocity Z-scores. Here's sort of a hint of what that might look like. This is my colleague, Dr. McCormack, who used bone mineral density in childhood study data, and she superimposed height velocity maximum versus peak bone accrual. And hopefully what you can appreciate is that, peak bone accrual occurs roughly about 6 months after peak height velocity. And this may be a reason that there's a vulnerability in teens and a certain time period for fracture because you're growing quickly, but you haven't consolidated that bone yet. A little bit more about the bone mineral density in childhood study. It was prospective, conducted over 7 years at 5 sites. And generally, these were over 2,000 otherwise healthy individuals. And to join the study, you had to have a BMI and a height greater than the 3rd percentile and less than 97th percentile. Not a lot of overweight and obesity in this population. Oh, and every one of these patients had a pubertal staging by a pediatric endocrinologist or a nurse practitioner who could do pubertal staging. Okay, so let's think a little bit about bone accrual. So this sort of mimics what you've seen with the height velocity here I'm showing you in green, males on the left, females on the right, Tanner stage 1, not in puberty. Pretty steady bone mineral accrual. Tanner stage 2, so very early puberty. Not a lot of change, perhaps a hint in our females of increasing. Tanner stage 3, now we're seeing more estrogen or testosterone, some now increases. Tanner stage 4, and now we're at the Tanner stage 5 level, so you're seeing a lot of bone accrual. This is bone accrual versus height velocity. The more quickly you're growing, the more bone you're accruing, again, converging with puberty. And then similarly, depending upon how much bone you have at baseline, will help predict how much bone you're going to accrue over the next year. And then finally, the more lean mass you're accruing, the more bone you're accruing. And again, a convergence of growing more quickly in youth and puberty. So this is complicated. So this is what it looks like, and I wanted to try and develop prediction, reference data for this. I did this during a sabbatical, not on my non-clinic time. Okay, so velocity was calculated over 11 to 13 months. Anyone who's a pediatric endocrinologist knows we're not supposed to do height velocity, say over 18 months or something. It doesn't work well. We did it for total body less head, lumbar spine, hip, femoral neck, and the 1/3 radius. These were sex and puberty specific, and the models were distinct. We either just adjusted for height velocity, weight velocity, because we recognize that not all centers would be able to do lean, have access to lean mass from a whole body DEXA, and then we also developed these for lean body mass accrual. Okay. I'm simplifying this. I'm not going to go through all the models for you, but on the x-axis is the absolute change in the z-score that you would get from a DEXA. You went from -5 to -2.5, and on the y-axis is the actual velocities. What I want to point out to you is that these, they're highly correlated, but they're not completely in agreement. Note that the x-axis is -2 to 2, and the velocity z's are much greater spread. And that's that line of identity there. And so in order to change a z-score by a whole standard deviation, you need to have pretty quick velocity. By the same token, if you are changing, if you're losing, a whole standard deviation or so, you need to have really low velocity. We appreciate this in the pediatrics as we see our kids growing. If they're changing a whole standard deviation score in a year, they really have stopped growing. Okay, so we developed the models and then we tested them. And we used 3 conditions: cystic fibrosis. We tried this, applied this to individuals who were no more than 2 years out from definitive treatment for their acute leukemia, generally about 6 months out. And then we looked at individuals who were starting on infliximab, a biologic for Crohn's disease. This is where it gets a little complicated, so bear with me. Here in the white, in CF, are the absolute changes in the Z-score. And you can see, not really changing much. In the red is the height velocity adjusted, in the blue, weight velocity, and the green, light lean body mass adjusted. And you can see that those are all around 0, so that they're not losing a lot of, they don't have a rapid or a low velocity, which is probably why those Z-scores aren't changing much. And I want to note that this is a very healthy population of individuals with CF. Okay, acute leukemia. So a little bit different. I'm going to focus on the hip here. Okay, what we're seeing in that after they finish therapy is that they have an improvement in their Z-score. And that improvement can't strictly be subscribed to their improvements in their height following glucocorticoid withdrawal or their lean mass. These kids tend to be overweight, so they probably already have a lot of lean mass. And so I have thought that this probably is related to withdrawal of the direct negative effect of steroid glucocorticoid upon bone. And then here's Crohn's disease, which I think is even more provocative. Again, you're seeing even greater increases in those Z-scores following treatment with infliximab. They are much less inflamed. And much of their improvements in bone density have been attributed to improvements in growth velocity and height, as well as to lean body mass. But if you look at these velocities are higher than even when you adjust for lean body mass accrual. And that suggested to me that perhaps this is related to that anti-inflammatory effect that's imparted by that biologic. So Mike and I decided that we would focus on velocity Z-scores. And so what did the endocrine promise sub-study look like? We obtained DEXA at multiple sites. It was only hologic because the BMDCS are based upon hologic. We did have some sites who had to drop out because they had to switch over to the other DEXA lunar. There was a standard operating procedure, and if anyone knows Babette Zemmel, knows she's very precise. Everybody had to have the DEXA done the same way. We used the BMDCS and Haynes and hologic, and here puberty was self-reported. And then we compared, I wanted to make some comparisons between what we get from BMDCS and what we get from NHANES. We pursued longitudinal mixed effects models for changes in BMDZ. The relationships with BMI, pulmonary function, and prior modulator therapy are probably of interest to you, but will not be presented here today. Dr. Shirley will be presenting them on Saturday. You heard Dr. Williams say I needed to adjust for height. I am not showing models adjusted for height here, but I will show you that I will say that the height adjustment didn't change our outcomes. And answering someone else's question, DEXA-defined body composition, those data are currently being evaluated by my colleague, Dr. Gilberg. And then we calculate these bone accrual velocity Z's, and we also did hip structural analysis. I'm focusing on youth for a number of reasons, but those data, that manuscript's about to be submitted for publication, so we'll have reference data for hip structural analysis for youth. Okay, here are the patient characteristics. As one can, and this is everyone, youth and our adults, 12 and above. Because this was a clinical trial, of course, COVID happened during that. And while I wanted my velocities over 12 months, COVID happened, and the good majority of patients could not be studied before there was a COVID shutdown. So I have largely 18-month data for that first visit, that follow-up visit. And these individuals are a little bit short on average, but not terribly short, and had good BMI. Okay, so what are these challenges of reference data? So in youth, these are NIH longitudinal data. And for adults, we use NHANES or company specific or local. NHANES uses whole body BMD. Enriched in obesity, this is really important for body composition. BMDCS, we tend to use total body less head or BMC. And then the whole logic, that reference data is, I think, less well described. And the reason I bring this up is that if you have an 18-year-old who has a DEXA, and then all of a sudden he's 22 and has a DEXA, your Z-scores may not be the same. And so you need to think about that because the reference are different. I'm going to show you some of that here. Here I'm comparing whole body DEXA from BMDCS to total body less head, which is what we usually use. And I'm doing this because in adults we use whole body BMD. If one were to do that, we don't generally get whole body. But you can see these are not in complete agreement. Sorry. Okay. And then here I'm comparing in just our adults BMDCS data to Hologic and NHANES data. And you can see that there's pretty good agreement except for at these lower Z-scores. And I suspect this speaks to what Dr. Malouf was saying earlier, is that we're still accruing bone, particularly in men, up until about age 25 to 30, depending upon the skeletal site. And this is shown a little bit more here. Sorry, it's taking me a little bit. I've already shown you this. This is Hologic on the y-axis, BMDCS for lumbar spine, total hip and neck. What's really fascinating, and I think, again, this speaks to what Dr. Malouf was saying, is that here I'm comparing adults who are anywhere from age 20 to, say, 55, using BMDCS, so bone mass at age 20, and comparing them to the adult reference data, which is age and sex specific. So it takes into account the normal continuing increases or decreases in bone density that are expected. And I think that this is particularly important I'm going to point out at the hip, because we start losing bone at the hip, particularly females, somewhere around age 18 or 20. And so you're seeing that the NHANES and Hologic are giving you higher Z-scores at the hip and the femoral neck than the BMDCS reference. Okay, going to come back to that. Okay, so here I am showing you now our longitudinal data. I'm showing you adults. And the only thing that was statistically significant, for whatever it's worth, is whole body BMDZ was slightly lower at 12 to 18 months, and that difference persisted at age at 24 to 30 months. Did not worsen. But we're not seeing any differences anywhere else. And I looked at a number of posters today, and I think they also showed that at least in adults, we're not seeing a lot of change in DEXA bone density following ETI therapy. Okay, now let's look at youth. Now we're looking at the left-hand panels. Again, whole body, here, lumbar spine, total hip, hip neck. Just wanted to review that these were on average almost 15 years old, great FEV1 at baseline, BMI-Z looked good, slightly short, negative 0.12. And again, I'm not showing you the height adjusted. What was really fascinating is that they actually had lower Z-scores. It's modest, but they were lower. And this was unexpected for me at whole body, as well as at the spine at 24 to 30 months, as well as at the hip and at the neck. The differences between 12 and 24 months weren't significant. They decreased in that first 12 to 18 months and didn't worsen over that time period. And this got me thinking, maybe this is related to some of the things that Melissa Putman was showing, is that is the bone expanding, or that is that inner circumference expanding? And so, but there isn't an bone deposition, so you're seeing lower density. I don't know. I'd love to hear what others in the audience think. Here are showing the data a little bit differently. I'm focusing on hip because it is so sensitive. BMD-Z change versus the velocity. And what you can see that probably the people who are driving the slightly lower Z are here. There are people who do gain over the 12 to 18 months. But I also want to recognize that there's probably some heterogeneity in the data just because these calculations were over 18 months rather than 12 months. And then what you're seeing here, similar to what I had shown previously, is that some people have lower accrual and some people have higher accrual. Looking at this slightly differently, I want to actually give you the values. Again, looking at our adolescents, focusing on total hip and neck. Here is the absolute change over that 12 to 18 months. And 24 to 12 to 18 months. And here what you're seeing is that they're going from negative 0.5 to negative 0.68, negative 0.6, negative 0.81. So not huge decreases, but they're there. And their velocities are sort of all over the place, certainly not higher like we would have liked. Similarly, what we're seeing at the next interval, so year 2 of ETI, things aren't really changing. And the velocities may be actually getting a little bit better, but we're not seeing that manifest in the change in Z-score. So, just a little bit more about hip. Adolescent, here we're looking at this narrow neck to give you a sense of what we're looking at cross-sectionally. Here's that cortical thickness. And what we're seeing is in that first 12 to 18 months, that cortical thickness is decreasing. That was unexpected. And that persisted at 24 to 30 months. Section modulus is a measure of strength, so how bending and resistance. That was lower than normal, but didn't really change over that time frame. Here we're looking at this in adults. Endocortical diameter. Here we go. So having a larger endocortical diameter is considered more negative with respect to bone strength. And you can see our adults with CF tend to have higher Z-scores at that for endocortical diameter. Cortical thickness was also slightly lower, and suction modulus was slightly lower. But we didn't see changes with ETI therapy out to 30 months. So, to summarize, among adults at baseline, across multiple sites, bone mineral density Z was decreased modestly and didn't change much over the 24 to 30 months with ETI, consistent with what I think others are finding. Among youth and our emerging adults, they also had lower bone density at multiple sites. They were modestly lower with 12 to 18 months of ETI. These decreases were largely sustained with out to 30 months. I would like to acknowledge that perhaps the velocity C are going to give us a little bit more granularity, and we'll be able to look at that with respect to changes in BMI and FEV1. And hip structural analyses were consistent with geometry and strength that were lower than expected than the otherwise healthy population. And pure speculation, but I wondered, was this lower cortical thickness may explain the lower Z-scores with ETI. But I'm new to the hip structural analysis field. So, an abridged version. Bone density is modestly compromised. And a look at that typo. ETI does not appear to improve bone density or bone accretion to any great extent. And if you're screening for CF bone disease in late adolescence, consider obtaining hip DEXA. And happy to take questions.
So I can ask the first question. Great talk, Dr. Kelly.
Thank you.
So am I understanding this correctly? So patients with CF who get ATI have decreased Z-score bone density, but they're not really losing bone. They're just not catching up with their peers. And part two of the question is, maybe they will, after a few years, that they eventually do catch up their peers and regain, get up on the Z-scores, maybe to zero.
I think you have that exactly right. I don't think they're losing.
Okay.
I think for the amount that they're growing and the lean mass that they're gaining, they aren't gaining as much. I don't know if that's because of changes in bone geometry or not. More to come there. But we are going out to 54 months. So my hope is that by going out to 54 months, we'll have a better insight into sort of the durability of these differences.
Okay, great.
Yeah, thanks, Ben.
Thanks. Question?
Hi, Andy. Thank you for that talk. It's Amy. My name is Amy Daru. Sort of unrelated, but sort of related. I did a small study on my own that showed ETI therapy does significantly improve or increase and cause bone age advancement. I was wondering what your thoughts are on, because I can't explain it, why I had those findings, and I didn't know if it had any relation to this or not, or what your thoughts might be.
Oh, it's such a great question, Amy. Especially since my colleagues, Marissa Kilberg, whom you know, has also demonstrated that there are a subset of kids who seem to advance through puberty rapidly and their bone age advances rapidly. Don't know what's going on. We did not get bone ages. We only had self-reported Tanner staging. My colleague, hopefully Dr. Williams, is going to soon publish about bone age versus DEXA Z-scores that will be able to interpret these data a little bit better, especially for our delayed puberty or advanced puberty patients. I have no idea. It's such a great question.
Thank you.
Isabel Same Paris. So you answered to my first question about bone age, but also I was wondering whether you could link also this DEXA data with also biomarkers of bone degradation or bone accrual, such as osteocalcin, for example, or OPG, rank
Great question. I do not have those data, but I did text my Rachel Walega during this that we need to measure rank ligand and OPG. Thank you, Dr. Maloof, for our patients. The problem in youth is that the best of my knowledge, we don't have great reference data, and you expect these to be increased, so they're very difficult to interpret. I think that we could get them. We certainly could get them in adults and see what's happening. They're just hard. Go ahead. Yeah. Yep. It's a great idea. Thank you.
Hi, Andy. Katie Larsenoni from University of Iowa. So when I saw this, and then I was thinking about the body composition that we have, the weight gain problems that we're seeing, the rapidly progressive puberty, and I had known about the first two, but I hadn't really seen your bone data, but seeing that together made me think of what we see with malnutrition recovery. So I don't think anybody's kind of articulated it that way, but the rapidly progressive puberty, the gain of fat mass before you gain lean mass is a classic starvation recovery phenotype. And I wonder, I don't know what happens to bone mass in starvation recovery, but I wonder if bone mass accrual is delayed the way lean mass accrual is delayed with starvation recovery. And that's different than Crohn's disease, even though Crohn's disease is a malabsorptive phenotype. That's a very inflammatory process. And I think we underestimate how much the exocrine pancreatic dysfunction and the gut dysfunction is causing malnutrition in our patients. And I think a lot of the weight gain is actually a reversal of malnutrition. What do you think?
I think it's a great.
I'm speculating.
Yeah, as we are all speculating here, so thank you for that. And do you think that that is exclusive to youth or adults as well? Because certainly we weren't seeing changes in the adults, Katie. So I will answer the question to the best that I can with what we're hoping to look at. So we do have body composition data that are coming. We now have body composition reference data for youth. So I think that's going to make this even more relevant. I think looking at BMI and seeing what these interactions are is going to be really important. And I do acknowledge that individuals with CF, particularly at those lower BMIs, tend to have that sarcopenic obesity phenotype, particularly even in youth. So there could be some element of that. In looking at the pubertal staging, it was hard to gather whether anyone rapidly progressed because we had 18-month interval and then this 12-month interval. We weren't seeing much in the way of changes in height Z to suggest that there was a subgroup of individuals who had really quick height velocity because of puberty advancing perhaps too quickly. Remember, though, that there were also 12 when we started, and average was 15, so many of them would have already been through, I think, fairly advanced in their puberty. But I don't think I can answer the question. Great speculation. Thank you.
Thank you very much.
Thank you so much.
Our final speaker is Dr. Jagdish Ulal from the University of Pittsburgh. He will finally tell us how to treat CF bone disease.
That's a tough act to follow. Thank you, Dr. Thankprecha and Dr. Wu, for inviting me to present, and thank you to the organizers of the meeting. Here are my disclosures, and what I'd like to talk about today is the treatments of osteoporosis or low bone density in cystic fibrosis bone disease, as well as talk about some of the pitfalls and maybe discuss an algorithmic approach to treatment. So there's a little bit of overlap with my slides and all the other slides because this is such an intertwined topic, but nevertheless, it's important to understand all the different things that go into the causation and the reasons for cystic fibrosis bone disease. It is really a multifactorial disease, and therefore it's important to know this right up front when we start treating, because we often start treatment courses and review the treatment a year or two later, and it's important to know what we're getting into before we treat, because we don't really want to come up with treatment failure and then realize a year or two later that there was a particular issue that needed to be addressed up front. So this is a cartoon that represents the treatment of CFBD as a tree, and we have vitamin D, we have calcium, physical activity, nutrient optimization as the basics of treatment. Now, how about endocrine replacement, exocrine replacement, pancreatic replacements that play an important role, gonadal hormone replacements and hypogonadism, avoiding medications that cause bone loss, and the water droplets are the various different treatments that are available for treatment, and we'll go over all of these in some detail. Now, again, just like I said, the multifactorial cause, it's also important to understand the secondary causes of bone loss. Now, these secondary causes are applicable to all different types of osteoporosis and low bone mass, but in CF in particular, which the letters that are in blue are patients with CF tend to be more afflicted with some of these issues: CF diabetes, for example, calcium deficiency, vitamin D deficiency, CF liver disease, malabsorption, celiac disease tends to be a little bit more common. Glucocorticoid use, PPI, H2 blockers that cause calcium malabsorption. They are mildly hypercalciuric. There's immobilization, chronic kidney disease, and major depression. So all of these causes are important to gauge and assess at the very beginning before we start treatment. Now, in terms of pharmacologic interventions, each age group is slightly different. Children and adolescents, young adults, postmenopausal women and men over 50. In children and adolescents, a vertebral compression fracture and certain aspects of the bone density score are used to start treatment. In young adults, it's a history of low trauma fracture and Z-scores as well. And in postmenopausal women and men over 50, it's a history of fragility fracture. And a fragility fracture is defined as a fracture from standing height, as well as T-scores and so forth. Now, a particular attention needs to be paid to people who are undergoing or awaiting a lung transplant because they receive systemic glucocorticoids, they are in bed for prolonged periods of time, and they tend to be a very vulnerable group. So we'll go over this in a little bit more in subsequent slides. So people who meet criteria for pharmacologic therapy, again, correct calcium, vitamin D deficiency, evaluate and correct secondary causes, if any, and looking at high risk and no prior fracture, possible treatment options include alendronate, denosumab, zoledronate, and pamidronate. How about patients who are very high risk for fractures and or have had prior fractures? Now, when talking to my patients, I say, I'm going to bring my big guns. And these are the big guns, the abaloparatide, denosumab, romosozumab, teriparatide, and zoledronic acid. Alternative treatments could be alendronate and risedronate. So now all of these are medications for treatment of osteoporosis. In terms of postmenopausal glucocorticoid-induced and androgen deprivation therapy, if you see a check mark, it is FDA approved. But in CFBD, we don't necessarily have an FDA approval, but we kind of co-opt the treatments, and some of these treatments have been looked into in terms of CF bone disease. Now, the ones in blue, teriparatide, abaloparatide, and romosozumab, are emerging anabolic therapies for CF bone disease, which we will shortly discuss. Now, how about bisphosphonates in CFBD? There are oral treatments, intravenous treatments that could be given weekly, monthly, every 3 months, or even yearly. A common treatment that I use is zoledronic acid because my patients in Pittsburgh come from far and wide, and we tend to have patients who like to minimize their visits to my center, and zoledronic acid tends to be a very easy option, but all of these other options are perfectly good as well. Now, how about let's delve into bisphosphonates a little bit more. Oral bisphosphonates are rather poorly absorbed. So a pill of oral bisphosphonate, for example, half of it gets absorbed, half of it undergoes first pass metabolism, and that half of it goes to the bone, and half of that gets excreted in the kidneys. So by the time it gets to bone, there's a little bit of it, but nevertheless, it has a very high affinity to bone. It preferentially binds to resorptive surfaces and induces osteoclastic dysfunction. Now, Dr. Malouf talked about the balance between osteoclasts and osteoblasts and how osteoclasts cause bone resorption. Bisphosphonates induce osteoclastic dysfunction and thereby affect bone resorption. It has a long skeletal half-life and can recycle. So treatments that, even if treatments are stopped, there's a little bit of recycling going on, and treatments can last a little bit longer after they are discontinued. One particular study, for example, the Canadian adult cystic fibrosis study, participants were enrolled and they received 70 milligrams of alendronate versus placebo for 12 months. 56 participants were enrolled. There was no effect on fractures, but they did see a significant increase in bone mineral density. And you may say, why were there no effects on fractures? And that's because there have to be a huge number of patients enrolled in the study, as well as for a prolonged period of time to see a fracture difference. And therefore, but it was there was significant improvement in bone mineral density, which was definitely a win. Now, in terms of all the other studies that have, and most of these studies are in the early 2000s, somewhere 2005 to maybe 2013 or so. You can, if I could point to the figure on the right, you can see that there is a slight bit of a tendency that favors bisphosphonate treatment, but not quite, because it crosses the line of unity, and therefore there's a favor to treatment with bisphosphonates, but none of these studies were carried out for long enough, and the treatment numbers were quite small. You can see here it's about 71 patients in total. So the numbers were small, the duration wasn't long enough, but it definitely holds a lot of promise, and I use this quite often in my patients. Now, how about denosumab? We saw how rank ligand and OPG are variable in patients with cystic fibrosis, and the denosumab is a monoclonal antibody of the Ig2 immunoglobulin isotype to rank ligand. There's a high affinity to rank ligand, and it's usually dosed every 6 months. There's a continuous suppression of bone turnover throughout the dosing intervals. The pharmacokinetics and pharmacodynamics are not known in children and therefore not used. We used to use a lot of denosumab up until a study that came out a few years ago that showed that denosumab cannot be discontinued without a proper alternative treatment. So if denosumab has to be discontinued, then we do have to have a plan in place to take the place of denosumab. Otherwise, there's a rebound, bone loss, there's vertebral fractures that occur in adults, hypercalcemia in children, and there's a slight risk of increased infections. So I still use this all the time in my patients, but it has somewhat fallen to second line in the treatment algorithm. Now, how about anabolic bone agents? Anabolic bone agents, let me start off with teriparatide and abaloparatide. Teriparatide is a PTH analog, and abaloparatide is an analog of PTH-RP. These are both injectables, and the difference between bisphosphonates and anabolic bone agents are that anabolic bone agents build new bone, whereas bisphosphonates preserve the bone that's already there and strengthens it. So there is a 2-year lifetime limitation, but a few years ago the FDA changed that, and nevertheless many insurance companies still kind of hang on to the 2-year lifetime limitation. But we see kind of a plateauing beyond 2 years in terms of bone accrual, and so therefore we again treat for 2 years and then plan for another treatment in its place. Teriparatide is also approved for glucocorticoid-induced osteoporosis and very positively impacts vertebral BMD, and therefore many of our people with CF who have CF bone disease might benefit because they are at higher risk for vertebral compression fractures. And each vertebral compression fracture causes an 8% loss in vital capacity. This medication is available as injections that patients administer themselves. It's a daily injection and tends to be quite efficacious. Lastly, romosozumab is also an anabolic agent. It's a dual agent, so it affects both the osteoclast and the osteoblast. It tends to suppress the osteoclast just a little bit, but also enhances the function of osteoblasts. It works through the sclerostin pathway by inhibiting the Wnt signaling pathway, and thereby that is critical for osteoblast proliferation and activity. There's a head-to-head comparison between alendronate and romosozumab, which showed superiority in fracture prevention. Now, this is not in people with CF. This hasn't been tested very well in people with cystic fibrosis. There are some anecdotal reports of romosozumab use, but has not been very rigorously studied. This is a once a month injection that's given for a 12-month time frame, and the dose is 210 milligrams. The FDA limited its use to a 12-month time frame because there was an increased risk of strokes and heart attacks occurring in the elderly. But fortunately, we know people with CF do not have a very high cardiovascular risk. So this is probably a plausible treatment that we could use for people with CF. Now, Dr. Williams touched upon the FRAX online calculator. This is not only used to calculate risk, but also to determine treatment. Now, let me point out that Dr. Tangpricha asked about secondary osteoporosis. Now, let's work this FRAX online. If you haven't used this, you can Google FRAX. Just click on the FRAX. It's free to use. You can use this tool. Make sure you pick the correct country and the correct race. So once we've done that, this patient is 115 pounds. That is about 52 kilograms. The height is 65 inches. And here's the height. None of these other factors, they're not on glucocorticoids and so forth. So we haven't picked that. We entered the bone density score at the femoral neck as 0.456, which gave us a T-score of minus 4.2. Now this, just like Dr. Williams pointed out, is validated for people above 40 years of age. So, and then you hit calculate, and here we get the 10-year probability of fractures. The major osteoporotic fracture risk is 16%, and hip fracture risk is 14%. Now, the thresholds for treatment are 20% for major osteoporotic fracture, and hip fracture is 3%. So this patient definitely met the criteria for treatment. Now, and Dr. Tangpricha, I did not hit the secondary osteoporosis, but you can imagine if you did, it probably increases the risk. Now, certain elements here have a much higher weightage. For example, parental hip fracture or current smoking tend to have a much higher weightage than, let's say, secondary osteoporosis. Now, how do you monitor pharmacologic treatment? There's online bone calculators that could be used, but more commonly, we use serial bone density scans yearly or every 2 years. And Dr. Williams pointed out the percent change from year to year or every 2 years, and that's a very important indicator of efficacy of pharmacologic treatment. Now, I brought this study up again after Dr. Kelly presented this. This one looked at both tibia and the radius, and the reason I brought up the radius is because the radius is a bone that's very, very susceptible to metabolic changes, whether it's hyperparathyroidism, hyperthyroidism, vitamin D deficiency. So it tends to be very, very responsive. And the ivacaftor made a difference. And so, in summary, I would like to conclude that as people live with CF longer, there is a need to identify and treat CFBD based on published algorithms to prevent osteoporosis in later ages. A proactive approach may be necessary by optimizing vitamin D supplementation, physical activity, nutrition, treating delayed puberty, timely initiation of pharmacologic therapies. It's important to pick the right treatment and constantly assess the progress with DEXA scans and remain vigilant for treatment failures. Now, I said highly effective modulators may alter the course of treatment. I may have to rethink that, but I'm hopeful that it will work. Hopefully. Right, Dr. Kelly? So I think
54-month data.
Yes. So with that, I'm going to end and open for questions.
You want to invite everyone up now? Okay, and we'll get to question.
Hi, great talk. My name is Ryan. I'm a pharmacist with the Innova Health System. I came from a background of primary care, and I've been with our team for about a year, and we're trying to tackle osteoporosis a little bit more. I think I've sent maybe 3 patients so far or had them talk to an endocrinologist, and they ended up doing zoledronic acid. And 2 out of the 3 had pretty bad infusion reactions. Now, I can't say whether or not, I need to go back and check whether or not they got pre-treatment before to kind of mitigate that. But is that something you've noticed in CF patients, or maybe not?
Absolutely, 100%. So particularly people with lung transplantation tend to be very, very susceptible to that particular reaction. There's an inflammatory reaction the very first time people get bisphosphonate treatments. And there is some published data in lung transplants where pre-treatment with prednisone the day before, the day off, and the day after helps resolve those symptoms. So try that the next time.
I would do that, but steroid.
Hi, Jonathan Zuckerman from Maine Medical Center. Great talk. And I think a lot of people who take care of adults would agree that we oftentimes identify patients with multiple issues when we get an abnormal DEXA scan. And so are you proposing a time frame for starting a biologic when let's say we identify somebody with vitamin D deficiency? If they have a z-score of, a t-score of less than -1, would you start them on a biologic at the same time as starting D therapy, or would you first replete them and then wait?
I would replete them, because you'd be just wasting the medicine by prematurely giving them. So I make sure they are on calcium. I make sure they have appropriate vitamin D levels. And I make sure I address some of the other issues before I start treatment, because once, for example, let's say I give them teriparatide, it's a 2-year time frame, and I don't want to waste that time frame by kind of not overlapping it with the appropriate treatment, because in the world of bone, time is very, very important. So, because as you can tell, it's a long duration of treatment, things happen very, very slowly, and so it's very important to kind of line up your ducks in the beginning, make sure everything is addressed, and then start treatment.
Thanks for their talk. My name is Amy Daru. Quick question. Do you have a preference in the pediatric population specifically regarding bisphosphonate therapy versus PTH? And also, if you do have bisphosphonate therapy, which one?
So in pediatrics, it would be almost preferentially bisphosphonates, because if their epiphyses haven't fused, then it's all anabolics need to be avoided. So I do have some 17-year-olds, and I'm very, very careful. I'm an adult endocrinologist, so I'm obviously, when I get a pediatric patient, I'm a little extra nervous, but nevertheless, I want to make sure that their growth has completed before I start them on any treatment.
Is there a specific bisphosphonate you tend to prefer in the pediatric population?
At 18 above, I cannot say for 18 below, but 18 and above, I've used oral bisphosphonate, alendronate. I've also used zoledronic acid. I've occasionally used other things like ibandronate and so forth, but my preference is zoledronic acid.
Okay, thank you.
The rest of the panel.
Amir Muhit in Minneapolis. Very nice talk, Jack. Thank you. So I have 2 quick questions, I think. One is, in terms of workup of secondary causes, do you routinely do or recommend doing a 24-hour urine calcium, concern about absorption of calcium? And number 2, any suggestions or guidance about when do you do a drug holiday from bisphosphonate in people with CF?
So that's a great question, because the calcium is a very tricky thing, in the sense that PO, the urine calcium is directly responsible, directly proportional to PO calcium and calcium absorption. So if they are not absorbing calcium, if they are not taking enough PO calcium, then their urine calcium is going to be low, and you're setting yourself up for treatment failure. So if the numbers are, if patients are coming to me with extremely low T scores or Z scores, then I really do a 24-hour urine calcium to determine if there is a calcium malabsorption going on. And sorry, so your second question was?
Drug holiday.
Drug holiday, I usually do 5 years and reassess. You can continue patients beyond 5 years if they are not improving, but I prefer to use a drug holiday for 2 years between 5 years of treatment.
Thanks so much, Dr. Ulal. We'd like to start the panel discussion, and I'll start with the first question. Sorry, Henry. Dr. Malouf, you've noticed that people with pancreatic sufficiency had much lower rates of the decline in their bone density. And Dr. Williams, you noted that the bone disease guidelines were published in 2005. What kind of comments does this panel have about updating those guidelines?
I'll go first. I'm newer to the field, but I have to say that when I've reviewed the guidelines, I thought that they do need some updating.
That's a good answer.
Regarding bone density reports, at least the US guidelines are much older. First about diagnosis, but also treatment has also improved, and maybe incorporating the newer therapies and their impact. I know that's evolving, but that's important too.
So I would agree. I think we've had so much more robust information that I think an update would be really helpful. My concern about the age group is that the burden to the patient, I still think they need to be updated. I'm not sure what all rates of DEXA will look like in the registry if we now say everybody 8 and up. I find there has to be, I think, a lot of more quality improvement measures on how we can, do better screening for the patient that's optimizing their time while still getting the appropriate data. So I think when and if those updated guidelines come out, that we need to really encourage community participation in the discussion. I think it would be very helpful.
I think we definitely need guidelines, but as you can tell, we don't have a lot of data in terms of anabolic bone therapy. So it would be nice to have some anabolic bone therapy in people with CF before we update guidelines. I know it takes time, but I think it's sorely needed. So yes, we need it, but not sure when.
I don't think my answer is any different. People have heard me speak loudly about needing an update, particularly with updated reference data for youth. I use the International Society of Clinical Densitometry, and if I were to interpret the more recent guidelines out of Europe, I think that they tend to rely on those from my interpretation. I still remain cautious, though, about screening everybody starting at age 8, because pediatricians are reluctant to give bisphosphonates in the absence of a fracture. Having said that, Duchenne's muscular dystrophy, other conditions where we know fractures are going to happen, we probably need to be more proactive. But in CF, if I have a very healthy patient, great BMI, FEV1 of 110, who's physically active, I'm reluctant to subject that person to a DEXA just because.
Can I make one point? The reason I brought up fat, because that's important, is in adults with obesity and gastric bypass surgery, there's a lot of bone loss. But the bottom line is, if you just changes in fat around the spine can impact bone density measurement. So as children and adults are gaining weight, if they've gained fat, that may somewhat alter the DEXA measurement at the spine. So that's why I brought it up.
Yeah, it also, I think, just overall increase in adipose tissue can impact the scanning precision itself, right? So it's important.
This is such a great point. And Babette tried to look back at all of these DEXA to see if there was like greater fat around the vertebra to see if this is why we were having these changes in Z-score. So thank you for validating that, and we can look at it again.
Hello, hi, Henry Celada here from UCLA. When you are looking for secondary causes for low bone density, do you always check testosterone even if the patient does not have hypogonadism symptoms?
So if they are you have to kind of take into consideration what else is going on. If they are having frequent CF exacerbations, if they're in and out of the hospital, their testosterone is probably going to be low. But if they have other symptoms, erectile dysfunction, low libido, all of those, then it might be important to make sure that the testosterone deficiency is corrected. But in general, as I don't do it for everybody.
Thanks.
Hi, Lenny Sicilian, Boston. Thank you for the presentations. Just in relation to probable new guidelines, Dr. Williams, you mentioned a number of tests that you can do for bone mineral density. Should we be considering these tests, or are DEXA still the gold standard?
So I think at this time, it's still the gold standard. It's what we have the most robust data for, and especially the limitations of cost or radiation when we're looking at a growing child or somebody who's undergoing CT scans, repeat chest x-rays. It's always really important to be mindful of. But I think as there's more studies looking at these other methodologies, we might find that maybe one type of scanning at a reduced frequency may offer us more information that will say, okay, DEXA is good for this, but this will give us the most impactful data on fracture risk, which is what we really care about. But I think we need a lot more information.
For now, are those other modalities limited to sort of research studies, or?
Yeah, primarily, yes. Yep.
Thank you.
Hi, Charles Stallman. I'm an adult pulmonologist in Nevada. This might be a bit of an unsophisticated question, but I was wondering if the comparator cohort for a T-score is healthy adults. How come we don't use T-scores for these young adults? I know it may not be validated, but it would seem to me that maybe the T-score lacks sensitivity in these younger people, but would be fairly specific if it is abnormal. I think I noticed a report of a negative 3.5, for example, on one of your slides. Caught my eye as pretty obviously abnormal. So is that something you use, or do you stick only to Z-scores, and why?
Go ahead.
So for young adults, they have not yet reached their peak bone mass. So we really don't know where they are in that continuum, and I think that's the rationale for using a Z-score. I don't know if Dr. Williams has something to comment on that, but I think we don't know where they are basically, and so we solely use Z-scores before when they are young. Postmenopausal women and men over 50, T-scores are perfectly okay.
Yeah, I would agree that the T-score data is based on the NHANES 3 group, and it's young, healthy females aged 20 to 29, where we'd expect more of that peak bone mass. So the Z-score, you're adjusting for their age and gender-matched peers, so it's a healthier measurement.
It just seems that abnormal would still be abnormal, would it not? I mean, I could see dismissing a normal score as maybe lacking specificity, but maybe this doesn't matter. Maybe just stick with the Z-score.
I'm sure.
So one potential example is if you take an 8-year-old with a
Yes.
T-score of -5, but a Z-score of 0,
Yes.
it's because they're well below the curve compared to a 30-year-old, but they're average for their age. They eventually are on that curve and will hopefully reach a T-score of 0. They'll reach a T-score of 0 later on. But at age 8, they're normal, But compared to an age 30, a t-score of -5 would scare you, but their z-score is normal. That's what, I'm giving an extreme example, of course, but just to illustrate.
So in pediatrics, I don't even look at the T-score. I ignore it.
All right, thank you.
It's sort of like having a child who's 8 and you have a height that is 4'2" and saying that they're short, but they're short compared to a 20-year-old, but they're not short compared to an 8-year-old.
Yeah, but I'm specifically asking for adults to adults.
Oh,
I mean,
adults.
a lot of our CF patients
Yeah.
are 20, 30. You know, I only see
Yeah.
young adults. And if the comparator group for a T-score is young adults, it just seems
The z-score and t-score in that case will be very, very similar.
Very similar.
All right. Well,
Yep.
thank you.
Yes.
Hi, Marina Litton, St. Louis. Great talks. Thank you for this session. Question, for longer-acting bone-targeted therapy such as alendronic acid, and with our young women now currently having a higher pregnancy rate in the post-DTI era, should there be a specific period that we should be advising patients not or try not to get pregnant after they receive bisphosphonates? That's my first question.
Great question. So they've looked at, specifically looked at pregnancy outcomes in bisphosphonates in CF. And there was a slightly higher issue of preterm labor, but it wasn't significant. So overall, the conclusion was there was no issue. Of course, the samples were small, but the overall conclusion was that pregnancy was not affected by bisphosphonates. Yes, we are very, very nervous about using bisphosphonate in women who are in the pregnancy age group, but I think CF could be used as an exception. There is data to kind of back us up.
And then just kind of as a follow-up to the fracs, how do you modify it for presence of diabetes if you don't have access to like the updated fracs that you have to pay for to get?
Secondary causes.
But it usually doesn't drive the score up too much.
It doesn't
right?
drive it. You know, it's hard to take into account diabetes, but traditionally in the old version, we've been using secondary.
We've been
I don't know,
adding
Dr.
10
Maloof
years
may
there. I
have.
don't know if that's like a, I've seen that recommendation.
Yeah.
The fracs 10 years to age for diabetes, but I haven't found that it's been validated.
Another way to correct for the presence of diabetes is to add TBS if you have trabecular bone score.
Yeah.
In general, diabetics have lower trabecular bone score, and so if you incorporate TBS for a diabetic, you already correct for that, potentially. I mean, there's
That's a
no
good point.
perfect data, but
Thank you.
Practical question. So I think I heard in a couple of the talks about needing to get the DEXA scans done at the same place, on the same machine. And I was just wondering, in the room, how many places have a DEXA scan at the same site as their clinic? We don't. So it seems like a good portion of people, the patients get their DEXA scan at another place. So that's oftentimes a challenge for getting the DEXA scans. And to me, as a CF program director, I know that my PFTs are always done at our center. We don't send them off somewhere else. And since bone disease is so important in CF, it seems like that should be part of an accreditation. I just don't know how expensive it is to have a DEXA machine at a hospital. But I suspect that it's due to reimbursement or something like that. Is that why most hospitals don't have DEXA scans?
I can't answer to the cost. I know from a reimbursement perspective, it's purely an outpatient procedure. So, you know, for somebody who's admitted, you can't get a DEXA scan on them at that time. The insurance won't reimburse. My only thought about is if you're having individuals going outside of the center, I would just tell them to make sure they keep going back to the same place and also verify, is there a lot of technician turnover? Are they properly calibrating their scans? Because if at least they're going to a place that's convenient for them, if they keep returning there, that's more reliable as if they're hopping around to different radiological offices.
and reimbursement for DEXA has decreased over the last 15 to 20 years. So less and less places are maintaining their DEXA instruments and replacing them. So maybe as an advocacy from the CF Foundation, that's one thing to maybe push for.
I want to thank everybody for asking their questions and make sure that everybody can get to the plenary. But if you have questions, the speakers are still up here. So thank you.